Welcome. This is Dr. Brian Buchanan from the Department of Critical Care Medicine at the University of Alberta. This is a module on LV function in the critically ill. This was taken from a earlier discussion of rounds in October on assessment of LV function in the critically ill. So why do we care about LV function in the critical illness? Well, I think for most people it's obvious, but current non-sonographic bedside measurements of cardiac function are either unreliable, such as clinical examination, or they're invasive. Patients with critical illness are often have complex medical and surgical illnesses that are poorly differentiated. And hopefully, discovering impairments in LV function may allow for an earlier intervention or therapeutic alterations to alter the trajectory of critical illness. And this can allow clinicians to understand the physiology of critical illness in real time. Furthermore, this may help with diagnostic categorization of hemodynamically ill patients, particularly those in shock. It may help to really narrow the differential, and can act as an ancillary diagnostic finding, such as diffuse B lines with reduced EF. Ejection fraction is highly suggestive of pulmonary edema. And ultimately, it may have an impact on therapeutic management. It may also have an impact on cognitive unloading, such as finding normal biventricular function in the patient with shock, where this may support another non-cardiac cause of hemodynamic instability. Overarching principles. So first of all, it's important to consider that it often requires multiple views in patients. I would encourage most people to acquire at least 2 images to make sure that they corroborate any hypothesis from the first image, as one image can be off-axis, leading to an under- or overestimation of LV function. And visual assessment of LV function demonstrates excellent correlation with more objective measurements, but there are limitations. And LVEF does not equal cardiac output. This is a well-known but little regarded fact. You may actually have an impaired left ventricular ejection fraction but a normal cardiac output, such as happens in cases of chronic cardiomyopathy. If we refer to the ACCP consensus statement on competence, this is a very helpful document to help guide our approach and framework for focused echocardiography. Helpful views to consider. First off, most commonly is shown as the personal long axis view, the personal short axis view, and the apical 4-chamber view. And finally, perhaps oftentimes most opportunistic in the ICU patient is the subcostal 4-chamber view. If we look at standard assessment forms of LV ejection fraction, many people reference the Simpson's criteria, which looks at changes in end diastolic and end systolic volume in 2 planes to get a more objective measurement of LV that's more standardized. At the bedside, this technique is not as useful or as appropriate due to things like time constraints. Focused cardiac ultrasound or goal-directed echo is really focused towards clinical integration in decision making rather than attempting to focus on discrete details. So while having more objective measurements of EF is important, particularly in long term, in the short term, having an idea of grossly categorizing LVEF is arguably more important. There are multiple studies showing that visual estimation can be done even after a relatively short training period. So how do we evaluate LV function at the bedside? Well, there are really 3 important parameters. First of all, myocardial thickening, next endocardial excursion, and finally E-point septal separation. First of all, from a myocardial thickening perspective, the myocardium should thicken around 25 to 40%. That's the average change in wall thickness. How do we quantify that? Well, we can do M mode, which is one of the original ultrasonographic modes of imaging, where the image is displayed really on the y-axis with time on the x-axis. In this sense, we can look at one component of the wall in time as it changes in thickness, and this would be called the fractional shortening method. This is often a bit more laborious and certainly not as rapid at the bedside versus just an overall visual eyeball method of looking at the LV. It's important to realize that one component of this is visualizing the endocardium to make sure we can actually see the entire component of the myocardium. And so just to emphasize, you'll notice that the LV cavity is circular in systole and end diastole. And so not only should the walls thicken, but they really should move inwards. And you'll notice the interventricular septum also tends to move inwards. It thickens and the endocardium moves inwards during systole. Next, we look at the E-point septal separation, or EPSS. This is how close the anterior mitral valve leaflet comes to the interventricular septum, which occurs really in early diastole. In most cases, in a normal ejection fraction, the anterior leaflet, seen here, will come within about a centimeter of the interventricular septum. This is a high sensitivity for normal EF. And so if this is impaired, there is a high likelihood of an impaired ejection fraction. Notably, things like a thickened or stenotic mitral valve may impair this type of movement. A reduced cardiac output will also have reduced excursion of the mitral valve, and also things like aortic regurgitation may reduce that swing of the anterior leaflet. So those are possible confounders of this method. In this case, we can see a comparison of screen left, which is normal, and screen right, which is significantly impaired. On screen right, you can notice that the anterior leaflet is really still quite far from the interventricular septum in early diastole. And so again, we can also see, based on this 2D image, that the ejection for the LV myocardium is really not thickening substantially and is severely hypokinetic, if not akinetic in certain areas. And so this is a grossly impaired EF. In this case, this was due to a reduced cardiac output and also likely some morphological changes in the left ventricle. So I can't emphasize enough, it is important to assess on multiple views to make sure you confirm any hypotheses about the left ventricular function. In ICU patients, in the nature of being opportunistic, you can often get a good subcostal window. And on screen left here we have our typical subcostal long axis, or also called subcostal forechamber, with the probe rotated 90 degrees. In the sagittal plane, we can see here that we have the LV short axis. And this is a very helpful view from a subcostal window to further help support any questions regarding LV function. So rather than directly quantify EF, from the point of care perspective, it suggests that really it be a visual estimate or visual categorization. And so the categories we really adhere to are, first of all, hyperdynamic, normal, depressed, or severely depressed. Because the reality is that it's important to really just have a gross idea of what the LV function is doing and have that integrated into the clinical picture. Here is a apical forechamber for you to view and make a quick decision what your thoughts are on the LV function. Okay, we can see here that the LV cavity, it's really reduced, if not eliminated, at the end of systole. And so in this case, it's hyperdynamic. And this is end-systolic occlusion of the LV cavity, or so-called kissing papillary muscles. Again, it is best to obtain more than one view to corroborate your hypothesis. Here's another ejection fraction here. We have three views: parasternal long axis, apical forechamber, and parasternal short axis. So if we look here on the parasternal long axis, I would suggest that there is reduced LV thickening and also reduced EPSS, which would place us in the category of a reduced ejection fraction. And overall, I would suspect that this would be a likely depressed ejection fraction. And so this would place in the category of 30 to 50%. Here's another image. First of all, just looking at it kind of from a gross pattern recognition, the LV does look really dilated. And again, there's that reduced myocardial thickening in the long axis on screen left. And overall, obviously, we're looking at a depressed myocardium here, again confirmed on your parasternal short axis on screen right. And so in this case, the EF is more in a severely depressed range. LV function recap. Again, obtain multiple views look for myocardial thickening, endocardial excursion, the EPSS, and classify into 4 main categories. Again, I cannot emphasize enough that consideration of contextual factors are vital. It's important to realize that normal LV function does not rule out congestive heart failure. It is a syndromic diagnosis, and plus, you have not ruled out for the presence of diastolic dysfunction. What you can say, if the LV function is significantly impaired, it is very likely they have diastolic dysfunction. Hyperdynamic LV function does not rule out lower cardiac output, as demonstrated, and clinical parameters are still extremely valuable. Some important limitations: tachycardic patients are very challenging to estimate from an ejection fraction standpoint, whether by visual method or by symptoms method. And so it's important to realize that they will require a repeat assessment when the heart rate is lower. Also, bradycardic patients tend to be quite difficult as well and tend to be underestimated. It can be very difficult to quantify EF in patients with a dilated LV and also significant regional wall motion abnormalities, such as a bundle branch block. Take-home summary points: LV function is a vital parameter to assess in the critically ill. It may have important diagnostic and therapeutic implications. We looked at several markers of LV function. We talked about using multiple views and avoiding foreshortening. And take your time and perfect your views at first to ensure they are on axis and they support one another in your hypothesis. And be sure to consider contextual factors. I'd like to thank you for listening to this module. You can follow me on Twitter at UAlbertaCCUS. Thank you. Bye for now.